Thank you. Well, good afternoon, everyone, and welcome to the weekly graduate seminar here at the Dahdaleh Institute for Global Health Research. My name is James Orbinski. I'm the director here at the Dahdaleh Institute, and I'm delighted to host Dr. John Amuasi. Am I pronouncing it correctly? Very good. I congratulate myself.
I must.
And John is going to lead today's seminar, which he has titled Learning to Shift the Goalpost, One Health Research and Policy. Now, as is our usual practice, before we begin the actual seminar, we're going to begin with a land acknowledgement that this is, in fact, Indigenous land that we're on. And I just remind people that this is a hybrid event. So some people are on different physical territories. So please take the time to give thanks and respect to the land on which you are actually physically on today as we do this seminar. And so today I'm here at York University campus here in Toronto. And York University is situated on the traditional territorial area known as Takaranto. And we acknowledge its current treaty holders, which are the Mississaugas of the Credit First Nation. We also acknowledge that this is the traditional territory of many Indigenous nations, including the Anishinaabe Nation, the Haudenosaunee Confederacy, and the Huron-Wendat, and of course, the Métis. And this territory, excuse me, is subject to the Dish with One Spoon Wampum Belt Covenant. And this is an agreement to peaceably share and care for the Great Lakes region. So with that acknowledgement, I'm delighted to give a brief introduction as to John's biography. John is a leading expert in tropical medicine and global health, a leading global expert, I should say, in tropical medicine and global health. And he's currently a senior lecturer and head of the Department of Global Health at Kwame University of Science and Technology in Ghana. And he holds a position as a professor of Global One Health at the Bernhard Nocht Institute of Tropical Medicine at the University of Eppendorf in Hamburg, Germany. He's also as a professor in Hamburg. He works independently to carry out research and teaching in very specific fields, in this case, global health. And John is a leader of the Global One Health Research Group at the Kumasi Center for Collaborative Research in Tropical Medicine in Ghana. And his research involves clinical and field epidemiologic studies on malaria, emerging and re-emerging infectious diseases, antimicrobial resistance, snakebite, and other neglected tropical diseases. He's quite an accomplished researcher. I don't think that's an understatement. Some of his recent papers are Pandemic Origins and a One Health Approach to Preparedness and Prevention, focusing on solutions to SARS and other RNA viruses. Another paper, The Berlin Principles on One Health, Bridging Global Health and Conservation. And then another paper I just mentioned is Reconnecting for Our Future, the Lancet One Health Commission. He was part of that really, really important Lancet Commission. John's going to present his research findings on infectious disease, or some of his research findings, not all of them, I think, but some of his research findings on infectious disease and One Health. And then he's going to discuss how to use this research or how this research might be used to better public health policy. Now, before I invite John to begin, I'll just remind everyone it's a 1-hour seminar. It will end promptly at 2 o'clock. People obviously have many commitments and so on, so we're going to be quite strict about that. And John will present for roughly about 20 minutes, just whatever is comfortable for you, John. And then we'll just we'll follow with a 20-30 minute question, answer, and discussion. And I'll wrap up pretty tightly at about 1:55, and so that we can finish promptly at 2. So I'd like to now ask John, welcome, and over to you.
Wonderful, James. Thank you very much. I must say, I didn't recognize it was you. because I've known James for several years now. He may not remember for us how far back I know him, but as far back as the days of the DND working group,
Yes.
way back. I was a medical student then, so I'm quite elated to meet with you again. So
Wow.
surprise, surprise.
Yeah, well, well, let's just put it this way. We're both a little bit older and slightly bearded. So
It's really wonderful. Anyway, I don't have so much time now, so I'll cut to the chase and get to the meat. This I titled "Learning to Shift the Goalposts: One Health Research and Policy," and I'm going to be spending most of the time just trying to expound on this topic a bit. I realize that the time is rather short to present actual research itself, so I'm going to spend more time just reflecting on what this means and why it's so important in One Health. So I'll start with this short video.
When they're down across the line, they storm the crease like bumblebees. They travel like a burning flame. We see them slide the hockey game. Oh, the good old hockey game is the best game you can name. And the best game you can name is the good old hockey game. Across the line, they storm the crease like bumblebees. They travel like a burning flame. We see them slide the puck inside. It's a 1-1 hockey game. Oh, the good old hockey game is the best game you can name. And the best game you can name is the good old hockey game.
Right. So much for shifting the goalpost. I think that brings it home. We're in Canada, so definitely
You've got our
to
attention.
Yeah, absolutely. I had to insert that. That being said, I did study in Minnesota, and there were often a lot of jokes about the competition in ice hockey. So I'm familiar with these. Shifting the goalpost or moving the goalpost has always been something that has been looked upon rather negatively. And there's been so much about, moving the goalposts, especially during this COVID era. And this cartoon you see there is an example of classic moving the goalpost. So it's something that's seen typically in negative light. And this just would be my outline. I'm going to speak about shifting the goalpost, what that means, complexity of One Health systems. I'll talk about One Health systems thinking, and then why shifting the goalpost is actually essential. It's not such a bad thing in One Health. And then I'll conclude with following the science. So let's start with shifting the goalposts. Just a bit of history around that. It is what it is, often looked upon as being negative, simply because it's as if you are trying to prevent someone who wants to achieve something otherwise positive, which is scoring a goal, from achieving it. So it's intrinsically looked upon negatively. So there is the classic negative goalpost shifting, which is what I call the fallacious goalpost shifting. You're actually wrong in shifting the goalposts. And you can see from the cartoon, I need not read it out there, but here's someone just shifting the goalposts based on the first question that was asked. Then there's also non-fallacious goalpost shifting. These are all my own terms that I've coined. And this is where shifting the goalpost actually is important, because maybe the goalpost was not well situated, or the question was not really clear. And so important clarification was necessary. Otherwise, the goal scored would be injurious generally. So in this case, I could refer to it as non-fallacious goalpost shifting. Now, I want to also give you an idea of some goalpost shifting that has occurred right from the days of Hippocrates. We have recognized that knowledge evolves, especially knowledge in the biological sciences. And it's sometimes hilarious when you read some of the knowledge from renowned scientists and thought leaders from back in the day, which obviously today have been debunked. One, really important one is humoral philosophy, where Hippocrates posited that an imbalance between black bile, yellow bile, phlegm, and blood accounted for health. Of course, we know this is not true. It was actually debunked by the germ theory, which in itself was found to be inadequate. So there's a constant dislodging of knowledge, or what we could refer to as shifting of the goalpost. But we love static knowledge. We we don't like to change things, especially when we believe in them. We like to establish the facts and we like to stick to them. But this static behavior involves both shifting the goalpost to suit our knowledge, but also failing to shift the goalpost when clearly it is necessary. So this is one, shamelessly shifting the goalpost. And I'm sure you've heard of flat earthers. It's amazing to think that there's still people in our world, I believe none of them live in Canada, who believe that the world is flat. And no matter what argument you pose, they will argue otherwise, that, well, we still can never really tell whether the earth is flat or round. So that's what I call shameless shifting of the goalpost. There's also the failing to shift the goalpost, which I talked about. And one classic example is of Semmelweis, the originally Hungarian and later applied his trade as a physician, as an obstetrician in Vienna, when he hypothesized that failing to wash the hands accounted for a lot of infections, especially among women who had just delivered and their children. So he just did some of it, an observational study. You can see the graph below there, and he showed clearly how when chlorine was used to wash hands, the numbers of puerperal fever reduced drastically. But what happened was that this observation conflicted with what people believed back in the day. He was totally rejected. He was actually castigated to the point that he actually had a nervous breakdown, was committed to an asylum, and died in 1865. It wasn't until Louis Pasteur came along with the germ theory, which was a theory which backed Semmelweis's observational study, because Semmelweis wasn't able to put a theory behind what he was saying. And then we know Linus Pauling's work, which clearly showed that hygiene was critical to surgical outcomes with regard to infections. But unfortunately, Semmelweis was dead. And this is a clear example of failing to shift the goalpost and what we call belief perseverance, even when we're wrong. And a good example of this is also in clinical experimentation, clinical trials, perhaps the heartbeat of clinical experimentation. And we know today, it's better these days, especially post-COVID, how any modification or change you have to your protocol requires an amendment. This can be expensive. It can be time-consuming, simply because we don't like to change, especially when it comes to this clinical trials. And now we have adaptive platform trials, which have caught on so well. I've been involved in a few of these, and it's still a bit of a challenge for many ethics committees and many regulatory authorities to deal with platform trials, especially in LMICs, but not only in LMICs, but globally, generally. A lot of questions as to why are you changing the sample size? Why are you dropping an arm and inserting another? No, you need to go rework your protocol. It's this rigor which we hide behind, but in actual fact, it's failing to shift the goalpost when it's absolutely necessary. And a good example is platform trials. And this is a very interesting one. I'm sure many of us have seen this in our EP lectures about the Bradford Hill criteria. And Austin Bradford Hill, really interestingly, did never call these 9 what we call criteria. He just called them viewpoints. But because we love to be static and fixed about our knowledge, we decided to call them criteria. And he seemed to almost have a foreboding that perhaps if he went too far with these one day, he would be turning in his grave, because people would say what he had said was all nonsense. So he said all scientific work is incomplete, whether it's observational or even experimental. He said all scientific work is liable to be upset or modified by advancing knowledge. So he was ready to shift the goalpost when it was necessary. And there's another interesting quote, just buttressing that point, especially in health, that we recognize need for change, but we're often resistant to change. It's a very interesting dichotomy. So let's go to the complexity of One Health systems. So the greater the complexity, the more we need to be ready to shift the goalposts, because when it's very complex, it means there is a lot of interaction, different moving parts, which may behave in different ways at different points in time on account of changes in circumstances, and therefore you must be ready to move the goalposts when it's necessary. And One Health is intrinsically very complex. And this is why I argue that shifting the goalpost in One Health is something that we need to live with, understand, although we need to do it carefully, and I will come to that. Well, these are just a few properties of health systems in general, which also would apply to One Health. And I'd like to touch on this point at the bottom left, which is by Antoine de Saint-Exupéry. He said, what is essential is invisible to the eye. So, and as we know, in One Health, with all these interactions, humans and other animals, and the shared environment, fungi, insects, whatever, there's so much that we do not see, not to even talk about the molecular level. And so what that means is that's even most essential and so complex, and definitely we will need to be shifting the goalpost. So what really we need to focus on is the need for trade-offs. And once you shift the goalpost, your focus is really on what trade-offs are you making. Ultimately, what you want is benefits, but you cannot be thinking about having just benefits without recognizing that you'll be taking risks and that you'll be trading off things that would otherwise, or in themselves, be looked upon as good or as beneficial, will need to be traded off. And this thinking is intrinsic in One Health, but is yet to be, overtly acknowledged. So these are, again, a few more fundamental characteristics of health systems, which I've already talked about and which reflect their complexity. These are the building blocks of health systems, which we know very well. And this is from the book, Everybody's Business, from back in the day, 2007. And it just shows the building blocks of health systems, but these interact with each other. But this is also an illustration of how the complexity of health systems pans out when you're looking at the difference between efficacy and effectiveness. I don't have much time to spend on this slide, but it just shows you how, because of how health systems come together and interact with one another, health system factors can make a big difference between efficacy as you've measured in your clinical trials or in the lab, in this case, by virtue of parasitemia clearance or parasitemia clearance rates for artemisinin-based combination therapies to treat malaria. And you can see here that lumefantrine was being used in East Africa, in Kenya to be precise, and then in West Africa and Ghana to be precise, artesunate-amodiaquine was being used in 3 different areas. And suffice it to say, you can see on account of these health system factors, the effectiveness overall was very, very low. It doesn't take anything away from the efficacy of the drug, but it's a failure to understand these complexities and therefore move things around so that you can have as close as possible system effectiveness as efficacy will lead to a lot of disappointment. And now if you juxtapose the illustration of health systems against the illustration of One Health, and I chose to use this one because this is the illustration that the One Health high-level expert panel came out with, OLEP. You already see that this is already terribly complicated, which should definitely tell you that a lot of moving parts, and I would argue the need for a moving goalpost. So that's the definition of One Health. I will not read it coming from the OLEP, also the description of One Health. And already you can see that's a whole bunch of things in there. It was surprising to think that we can have things static and that this will stay as it is, or what we need to do to achieve our One Health aspirations would always be the same, given that things, especially a lot of the things that are listed in this description or definition, are constantly changing. So why would I argue that One Health systems thinking is really important? It's because you want to avoid this black box conundrum where we know what will happen, or we think we know what will happen once we put in one or two, make one or two inputs, but we don't really understand what is going on in there. And the illustration you see there is just understanding biotransformation occurring in wastewater. And this is just how microbes break down whatever may be in wastewater and use that as their quote unquote food. That alone is so complex in its own self, as you can see from the box in the right. And understanding that microcosm alone is a whole somebody's life work and even much more than that. And this tells you that One Health is so complicated from whatever angle that you look at. So we cannot afford to operate with the black box kind of paradigm when it comes to One Health. So systems thinking would place a high value on understanding context and looking for connections between parts, actors, and processes. And context changes. Context changes all the time. And therefore, what we require is a deliberate, continuous, and comprehensive process. And essentially what this means is you will be shifting the goalpost. And so this is where you would like to apply reductionism in One Health systems, and argue that it is one of the basic tools to understand health systems. So just like if you want to apply reductionism in medicine, the doctors will take apart the human body, identify the heart, the lungs, kidneys, all the various systems, and apply knowledge of that to diagnose and therefore treat a disease. And we can look at an example of someone coming to the doctor and saying, I have diarrhea, and this is how the doctor will think about things. Okay, gastrointestinal system, all right, absorption issues, gather a bit more information, maybe gets to understand that it's very loose, rice water looking kind of stools, which have a fishy smell. Well, if you're a medic, obviously you would know what this is. We're talking about cholera, and you may be pretty right almost 99% of the time. And then you can prescribe, even perhaps without conducting a lab test and all that. So we'll call that biomedically very, very easy. And if you want to put this into a reductionist table, that's what you would do. You would look at the organ systems, think about the cell types in the organs, and look at the physiology, and you'd come to a conclusion as to what's going on, come to a conclusion as to what must be done, and how to monitor to determine how well your intervention is working. But let's think about reductionism in One Health systems, and a situation where a village local representative says, okay, pigs in the community started having diarrhea, it started dying. And well, because we are poor, we started eating the dead animals because we didn't want the meat to go to waste. But then people also started dying from diarrheal diseases, and people are now alarmed. How would you go about applying reductionism in One Health systems in this regard? Or obviously, you see that you'll be scratching your head because it's not as simple as you would apply reductionism in biomedical science or in medicine for that matter. You may want to think about One Health systems, as I like to put them. What would be your organ systems? What would be your organs? What would be the physiology involved? What would be the basic subsystem? And you can begin to plug in a whole bunch of things in there. You could base this on the building blocks of health systems if you wish. But then all I wanted to show here is the difference in complexity when you think about medical reductionism relative to One Health reductionism. And again, this is why shifting the goalposts is actually essential in One Health. So why would I say so? Again, because dynamism is a property of One Health. And the OLEP illustration demonstrates this. Then also in One Health, the goalpost actually moves naturally. At times we need to shift it ourselves, but it does move in itself. And if we need to shift it ourselves, there's a couple of reasons why we need to do that. And I'll go into these 3 reasons, one after the other, why we must shift the goalpost ourselves as might be necessary. The first one I want to point out is that there is evolution of knowledge. Once there is better research, there will be better data, there'll be better analysis, hopefully, and hopefully that will mean better policies, and better policies must result in better outcomes. And once we understand this, we become more comfortable with the notion of shifting the goalposts. The who, the what, the where, the when, as we always talk about in epidemiology, are never static. Maybe the what, maybe we can come to a firm conclusion about the what, if the science is advanced enough. But the who, the where, and the when, these are always changing. And once they're always changing, we may as well be ready to shift the goalposts. I'll just give an example, just a couple of pictures as to the different whos that we have on the planet. This is just limited to human beings alone, such variation in the who, not to speak of the animal kingdom and its variations. Think about even insects and fungi alone. There's so much variation. And the what, a lot of things going on in the world today, from bushfires, Australia, Canada have had their fair share, the US, and even North Africa and the Mediterranean regions have had their fair share last year. And the implications, climate change implications, the where, all kinds of places, beautiful places all over the world, but very, very different places with different people. The when could be different climatic zones, different climate timings, and it could, and this is just that picture that you see at the bottom left is the same tree at different points in time. So these are all reasons why achieving One Health goals is like chasing a moving target. Because if you think only about where it is happening, it has its own set of solutions. When it is happening, it has its own set of solutions. And so if you pursue these independently, without applying a One Health approach, and without also applying One Health systems thinking and recognizing the need to be shifting the goalpost to meet that One Health target, you would have an unsynchronized solutions and you'd have problems because you'd be chasing the goalposts and you'd be moving all the time. So therefore, what you want to do is to think about all these together using One Health systems thinking so that you can hit the bullseye and therefore achieve these One Health goals that we desire. And this is what I have termed W4 solutions, One Health solutions. That's the who, the what, the where, and the when as applied to One Health. I'm sorry I'm moving a bit fast, but there's a whole bunch of things I wanted to try to touch on, so I'm trying to move to the more important ones. Just a good example of how things have changed, just using COVID in itself. Strong spread rate, fast antigenic shifts in lineages end up activating the power of the vaccines. So we once thought that vaccines, or we thought that when we had vaccines at first, we knew problem solved. And later we realized that was not so because things were changing so rapidly. And so we needed to be changing the vaccine also. And this met with a lot of ire from the general population who thought, and that was the truth, that the goalpost was being shifted, but we needed to shift the goalpost. This is a beautiful paper that does a good job of looking at the evolutionary events of SARS-CoV-2 and global public health and juxtaposing the infection rates, the deaths on the variants that arose and changes on the spike proteins that we're seeing right from 2020 through to 2022. And that alone just tells you how quickly this evolved. It meant that we needed to shift the goalposts in many different things, from masking policies to social distancing policies and so on. Not to even speak of even vaccination policies regarding vaccination regimen. There's also another one that just shows changes in or possible hypotheses regarding the emergence of variants of concern. One hypothesis was just focusing only on human circulation and how that may have been driving variants, the emergence of variants of concern. There's another hypothesis that was also looking at the involvement of animals, which is a plausible hypothesis. And if you think about the various animals that could be involved here, not only wildlife, but domestic animals, and the different options for wildlife that exist and what that could mean for variants of concern emerging. And then also there could be the other hypothesis of just it happening in individuals and how individual immune systems and human behavior in itself could drive the emergence of variants of concern. And these alone just show you how there were so many important variables which are rapidly changing, and these would impact on One Health approaches and impact on One Health outcomes. So we can think about antimicrobial resistance, for example. There is, also as it was, is a strong hypothesis that use of antibiotics in farming is the culprit or the main culprit when it comes to driving antimicrobial resistance. But more recent research is showing that, yes, it's a plausible hypothesis, it does apply, but it does not apply across the board. Not only does it not apply across the board, but the mechanisms differ significantly between high-income countries and low-middle-income countries. And this is one of the findings from our Lancet One Health Commission, which hopefully we will publish later this year. This diagram is not from the Lancet One Health Commission, I must point out. I'm just using this as an example to show you this. Also, another one is looking at the relationship between non-communicable diseases or the One Health implications of non-communicable disease or vice versa. Another important one, because we begin to see how a lot of changes in our world would have implications for One Health, not from a zoonotic standpoint, but just also from a non-communicable disease standpoint. And these are so critical, especially when you think about the current burden of disease findings and how a lot of these non-communicable diseases are really charging to the top in terms of burden of disease. And you already see how One Health has a critical role to play in their climate change. We know all this really well. This is from the WHO 2021 publication, but just showing how climate change does impact significantly on health. And one clear example is just a 2 to 3 degree increase in global health, in global average temperatures have implications for vector biology, proliferation of vectors like insects, sand flies, house flies, black flies, and the like. But specifically for mosquitoes, Anopheles alone, it could increase risk of malaria by 3 to 5%, including the possible reemergence of malaria in the global West. And finally, we are also seeking to modify our value system. And if we're seeking to modify our value system, it even makes it more important in One Health to shift the goalposts. And one of the key things in One Health education is trying to shift value system. And I'm just going to, I may have to skip a few of these because of time, but I'm just using rabies control as an example of the challenges involved in reorganizing our systems to address One Health challenges. Would it be the Ministry of Health responsibility, or would it be the Ministry of Agriculture's responsibility, under which in many countries the Veterinary Services Department finds itself? Rabies is spread by dogs, and rabies control involves addressing stray dogs and vaccinating dogs, and will not be the Ministry of Health, it would be the Veterinary Services. However, they are under the Ministry of Agriculture. So who's going to pay for it, and who's going to take the glory when there's success? Already really complex issues that come into play, again, requiring a different way of thinking when it comes to rabies elimination. And not forgetting that rabies is also a neglected tropical disease, an NTD, and therefore would fit, the NTD program would be under the Ministry of Health. So already you can see the complexity there. So how can we operationalize One Health across sectors? And I've taken some of this from the work that we've done in our Lancet One Health Commission, which, as I mentioned, will be published hopefully very soon. And these are some of the challenges that we have in operationalizing One Health, especially when you think about the need for us to change the way we value things on a global scale. Why would a tree in a forest somewhere be of less value than the same tree as a log in a container somewhere else? These are all questions that we need to answer from a One Health perspective, and the need to shift how we value things, not only from a values perspective, but also intrinsic value or economic value for that matter. So these are just some of the barriers. I'm sure you can read them for yourselves on the slides. And there's always the perennial problem of funding, which never seems to go away, but also raises the important questions of how we will fund these One Health research and One Health systems thinking work that needs to be done. So I would just touch on some of the human health issues when it comes to challenges with operationalizing One Health. I will just flash the slides one after the other because of time. I just really want to make sure that I leave enough so that we can discuss some of the arguments that I have put forward. But I want to touch specifically on the bottom left one, which is the increasing public awareness and education about One Health as being key to sustainable development. This will help making the shifting the goalpost more comfortable, and I'll explain this in another slide also, not just saying we shift the goalpost anyway, anyhow, but also being very careful and doing this properly to make sure that we have the outcomes that we need. But until the public is with us on this One Health journey, understanding this way of thinking, it becomes very difficult, and we would be accused of shifting the goalposts, and it would be applied in a negative sense. There's also the animal health issues, which are challenges in operationalizing One Health. I've already talked about this integration at the government level, but also making sure that we're able to strengthen regulations in trade and movement of animals, at the same time being respectful of people's traditions and cultures. There's a lot of talk about banning wet markets, etc. Yes, scientifically makes a lot of sense, but I found it totally disrespectful of people's cultures that have been handed down over the years regarding what food to eat and so on. People even went as far as saying we should ban and make it illegal to eat bats. It's totally disrespectful of some people's menus. All right, environmental health issues are also perhaps maybe at the center of it all. And thinking about even things like climate change and how that impacts on One Health. I've already talked about the One Health implications of communicable diseases and vice versa. And so the environmental issues are so critical when thinking about the challenges around operationalizing One Health. And this is where we at the Lancet One Health Commission speak about avenues for One Health operationalization. And we talk about governance priorities, economic priorities, and knowledge priorities. And I'll just touch on a few of these, maybe one of each of them, again, because as I said, we're yet to publish these hopefully very soon. But we talk about these pathways to operationalizing One Health. The first one is the governance priorities, recognizing that until we have governance frameworks that are applied at the global level, at the national level, and then at the local levels, we will have a lot of problems. We already see how we are struggling with the pandemic treaty. And it's looking like it may not happen at all, or even if it happens, and the World Health Assembly is just around the corner, even if it happens, it will be already a very watered down version of the pandemic treaty, all because special interest seems to continue to win the day. But governance would be absolutely critical if we want to be successful in operationalizing One Health. Then there's the economic priorities. And for this, I will just say that we need to recognize that the current global economic paradigm of GDP just does not cut it for One Health, especially because it promotes an extractive approach to economic advancement and does not recognize the destructive outcomes of this extractive approach, and therefore a complete change in how we create economic value is required. It's what we refer to as a slow radical change is what is required, and that obviously is another form of shifting the goalpost in itself. And how do we establish these criteria and these metrics for measuring these? And finally, I'd like to speak to the One Health avenue of knowledge priorities. We need to acknowledge and explore different ways of knowing. I remember when I was doing my PhD, I took a minor in development studies and social change, and there was a course called Ways of Knowing. It was my favorite course because it was like I had a light bulb moment when I recognized how there's so many different ways of knowing the same thing that we think we know. And until we recognize this and develop a comprehensive approach towards disseminating global One Health values at different levels of society, as well as among different disciplines, we will have challenges in the way we generate and apply knowledge, and also making sure that this is done at a very fundamental level. A lot of One Health focus has been at the tertiary level, but we need to have this transcend to the secondary level, i.e. high school level, and even to the primary school level, because it's a way of thinking that needs to be carried all the way to the top. So the steps are complex, the process is long, but when we are set on promoting healthy, sustainable, socio-ecological systems, which is the thrust of our One Health Commission, i.e. One Health, we would aim at doing things healthily and safely as might be reasonably practicable, but that means the goalposts will need to be shifted, because what is reasonably practical to be changed with research, learning, and innovation will often change in itself. And I conclude with the last 2 or 3 slides with following the science. One Health inherently involves continuous improvement, learning from what goes wrong and what goes right, and making changes. So in that respect, shifting the goalposts. So if we want to follow the science, it means that we will need to carefully, boldly, and decisively, and yet reflectively and respectfully move the goalposts. So we need to recognize it's okay to move the goalposts, especially when we are the ones who constructed those goalposts and installed them. So we set the criteria, we generated the knowledge. So it's okay if knowledge has improved or has changed, and therefore shifting the goalposts. So we should have it more like a fishing trawler's net. We go where the fish are, right? Rather than just keeping the net in one place. So think about issues like One Health surveillance. One Health surveillance is something that's been touted a lot, but are we ready for what comes with One Health surveillance? One Health surveillance means that you're going to be seen a lot. What's the point in seeing a lot but not being able to act? Acting comes with a lot of financial obligations, which I believe the world is not yet ready for. So while we're pushing One Health surveillance, which I totally support, where's the money to engage in the actions that will be necessitated by what we will see and find if we engage truly in One Health surveillance? Then think about the cardinal role of implementation research and operational research, and especially science communication in this sphere. And it's not surprising that many academic institutions have recognized this and therefore have units or departments that promote translational science, because they know that without this, it becomes very difficult. We still need to follow the science. And this cartoon just is one of many which vilified Dr. Anthony Fauci because he was shifting the goalpost based on the knowledge that was being generated, but was not looked upon kindly by many people, especially including in the science world and the general public as well. It comes with its own risk. It's uncomfortable. In our Lancet One Health Commission, part of the work we did was looking at economics in itself with regard to One Health, and we had problems securing classic economists to work with us. The reason was that many of them were afraid of being ostracized by their community of economists, because the thinking around economics when it comes to One Health is radical and will require putting forward some radical thinking. So it's not surprising that proponents of things like the donut economics, which Kate Rayworth put forward, and others who have sort of secular economics and so on and so forth, that others have put forth, have led to these individuals, although they are famous, being sidelined by your classic economics community. And my last slide, truly last slide, is just this recent news, I think that's from yesterday or 2 days ago, where the once hailed AstraZeneca COVID vaccine savior of the world is now facing a legal suit because it has finally been accepted, acknowledged that the vaccine can cause a rare side effect of blood clots, which can lead to death. So it's not only in the popular media. This is from the Daily Telegraph, one of the UK's biggest newspapers, but the one on the right is actually in the BMJ. So it's also found itself in the academic literature. But if you look at the benefit that has come out of this AstraZeneca vaccine, one would say, yes, we should do the same thing under the circumstances any day. But it requires a shift in the goalpost to say, actually, now we realize that this thing can be a problem, so we need to use other options or adjust what we were doing before. That is a challenge. It's something we need to live with in One Health. So solutions that move beyond business as usual require using evidence from science to reassess the relationship between people and nature. This is from the IPBES report, which I'm very proud to say I was a part of that IPBES pandemics report, which was led by Peter Daszak from Equal Health Alliance, and which was published, I think, in 2021. And with that, I'd like to say thank you very much for having me.
Well, John, you're packing in. And I'm particularly happy that you started with Stompin' Tom Connors, and who's a Canadian icon, and you sure got our attention with that. There's so much in your presentation, and each element is very nicely explored, and you give us a lot to what you challenge us, right, with different ways of thinking. I just have a comment that and I'd love you to reflect on it. You know, when you talk about shifting the goalposts, it really reminds me of Thomas Kuhn more than anybody else, and the theory of scientific revolutions, and how knowledge is a constant and ever-changing process. You know, Kuhn talked a lot about the nature of science, and essentially, I mean, I know this is being recorded, which is unfortunate, but it means then that this will exist in perpetuity. But my conception of Kuhn's really seminal work is that science is it's a methodology. It's not an endpoint.
That's right.
Right? It's a methodology more than anything else that gives us a closer approximation to truth. But that through that process, one never arrives at truth.
That's right.
Right? And therefore, what we conceive of in any one particular moment as so-called fact will, in fact, be altered at some future point. And so you characterize that as shifting the goalposts. You gave us a great historical kind of analysis of the evolution based concepts of medicine and health, and public health. And I think that, you know, so if we take that idea that knowledge, I mean, it's really kind of what you're talking about is you're kind of demanding a second renaissance, right? A second invitation to new knowledge from a global planetary health, One Health,
Yeah.
Eco health perspective. So now, if I listened, I'd sort of kind of go from that starting point through all of the various elements that you described. It seems to me that probably the biggest challenge, it's not the elements, it's not the silos, you've done a great job just kind of giving us what they look like. The biggest challenge is the story. How do we tell this story?
Exactly.
Right? And how do we do it in a way, you know, you said at one point in your presentation that if the public is not with us, we're not going anywhere. You said something like that. And I think you're just dead on. And the issue now is the story. And what is that story? And how do we tell it in a way that is as compelling to, you know, young students and graduate students as it is to policymakers, as it is to communities in you know, Burkina Faso, who rely on bush meat, for example. So that's really my biggest comment, and I'd invite you to reflect on it. And then if anyone else has any comments or questions, I'd love to ask you to pose them. Go ahead, John.
No, thanks, James, for those reflections. Really apt, and it's a pity we don't have more time to really discuss these. I just want to go back to one of the slides I showed, which is about this humoral theory, which Hippocrates put forward, which of course we know is not what it is in reality, but he was right in his general ecological theory, where he did say that an imbalance in the human relationship with his environment and animals and work and relaxation of work and play, imbalance and with the environment animal was actually the heart of disease. And we sort of moved away from that into, after the germ theory, to this pure biomedical approach where we thought that, okay, we can explain everything and antibiotics are going to solve every disease in the world and so on. And we're only now sort of coming back to this fundamental understanding. So that's an interesting one, because that is it. We're not going to be shifting that goalpost, that it is really this finding this balance of and the need for all these elements to be present. And again, this understanding of the need for elements to be present is what is informing now these green movement in cities and so on and so forth, and moving away from the concrete jungles that we have built, because we now understand that actually we are doing ourselves a great injury by creating these living places and spaces that that actually are injurious to health. So i.e. the cleaner we get, quote unquote, cleaner we get, actually, the less healthy we are getting. And again, I put this strongly inverted commas. So that being said, the key is being able to bring the community or the population along in this way of thinking. We like to say that science is it. So the science is very definite, it's very clear. How do we get people to understand that, okay, we don't know everything, this is what we know, and as and when we know better, it will change. Politicians don't like that. When they come, first of all, they didn't or don't like coming to our scientists. And so we tell them that this is it. They use that for their political, or it's always politically colored. They do their thing and later, oh, actually it changed. So they're not very happy with the science, and they think that it may be safer to do away with the science and just to do the politics, because at least the politics, you can spin it as long as you want. So what this means is, if we are able to get the public, and this is why I talked about One Health systems thinking going down to the basic educational level. So even in primary schools, in high schools or secondary schools and so on, once this way of thinking becomes ingrained, it becomes the norm, it will become much easier to appropriately shift the goalposts when we need to. But so far, we've concentrated a lot at the tertiary level and not enough has seeped down. It's going to be very difficult to take the general public along.
Mary, and then Godfrey. Go ahead, Mary.
I'll try and be quick. Thank you so much for that great presentation. Conceptually, really interesting. I would like to, when I think of One Health, I think about intersectoral work and whole of government approach. And yet what we see, for example, in the pandemic treaty, the latest one that's being negotiated as we speak, in the preamble, it talks about the WHO being the coordinating agency. No reference to the quadripartite. And I was just so, Raphael and I were invited to advise the Canadian government. So we said, well, get the quadripartite at least mentioned. And so I'm just, if at that level where, One Health is really essential to any kind of a pandemic treaty, they're still not getting it. Because I think my concern is that at the national level, they also have to get it. And it's got to, kind of be infused throughout the world in each state. And if at that highest level, they're not communicating properly, whole of government is empty.
Mary, you really nailed it right there. And it's also because of what I call special interest. You recall in one of my slides, I talked about trade-offs. So we're looking at the benefits, but these benefits, to achieve them, require taking risks and then also trade-offs. And when many developed countries look at the trade-offs that they need to make, they become unwilling. And this is why the pandemic treaty has been so watered down. And thankfully, we got the leak of, the US and Germany. I don't know if Canada was part of the gang, but at least I know US and Germany were part of really trying to water things down, not because they just wanted to be mischievous, no, but because they want to protect their economic interests. Again, Canada was part, of the game. Okay, but the reason is they want to protect economic interests, and it's again speaking to what I was talking about. I was referring to the current global economic paradigm. If the economic interests or economics is shaped as it is now, there'll always be interest in that kind of economics, totally antithetical to One Health. So it's a really holistic change that's needed. Otherwise, we'll just keep going around in circles. I don't have a solution right now. That's why I call it a slow, radical change, but at least recognizing this complexity and beginning to tackle it from the outset would be critical. I don't know how much leverage the G7 could have on the pandemic treaty, but I think it's not been discussed enough at that level. And that's why there's challenges, because if at least the G7 can agree on certain things, it won't be seen as someone is going to be losing, because at least they would have some agreement around certain key elements they'll be able to trade off as a block. But we know that this is already going to be very difficult. I recognize time is almost up.
Thank you, John.
Oh.
I'm going to pause Scotford's question. He can talk with you after.
Yeah.
But I would just like to thank you for really giving us just a wonderful overview and giving us some real challenges. Here at York and the Dahdaleh Institute, we have quite an extensive expertise, if you will, in a number of different areas that are relevant to One Health. And this is the first time that I've seen a presentation that actually gives us the big picture and actually captures the subsystem complexity of that picture. And that's a real accomplishment. So thank you for that. And we're delighted that you've joined us, and we look forward to finding ways, creating ways to collaborate in the short and medium and long term. So thank you, John. Thank you.
Thank
And
you.
with that, thank you. Let's just not get out of there. Right. With that, I'll just note that our next seminar is next Wednesday, May 8th, and it, excuse me, will be presented by Rajneesh Prasad, and it will be on gender inequality in health across life cycles in India. And with that, I'll say our seminar is now closed. Thank you.
Thank you.